So resuscitation of someone with pancreatitis. So, traditionally it's like 8 to 14 liters. So I give 14 liters of fluid, and then we'll go from there and see if they get better, right? But there is no evidence that did this. We knew in '74 that more than 6 liters by research. It wasn't like someone's expert opinion in 1974. It was like they did research and said, hey, those who had got more than 6 liters of fluid for resuscitation, they did bad. Okay, and if we knew that abdominal compartment syndrome we talked about in GI, right? The place in the body that's more inflamed is going to be the leakiest, right? So all the fluid that we do give, all 14 liters, right? When you have a leaky bowel, right? That's where all of it is going to leak too. When you have a leaky pancreas, that's where it's going to leak as well, right? So we talked about the bowels being leaky, but now the pancreas, which is not pictured here, in the back is going to be super leaky, and all that fluid is going to start, leaking out to the point where the pancreas is not going to get better because it's going to be compressed, but also it's going to start causing localized inflammation of the bowel, and it's going to cause more, bowel ischemia and more pressure on this whole system here, and that's less blood flow back to the heart, and that's less blood flow to the pancreas. And what caused necrotizing pancreatitis was low flow to the pancreas. Well, shoot, that's why don't we avoid that? So we avoid that by starting pressors early, right? We knew 6 liters positive was poor outcomes back in the early 70s, right? So we want to avoid that if we can. So our goal is about 2 to 4 liters tops, right? And over 24 hours. It's not like a huge bolus right here and there, right now. We want to keep the eyes and nose even after that point, right? Start to get them corrected, and get our vasopressors on board to maintain perfusion to the pancreas, but also to our kidneys, and of course to our heart and such, because we know multi-organ dysfunction syndrome or multi-organ failure has a high mortality in itself. Every organ that shuts down is about 25 to 35% mortality, right? So I have a pancreatitis, already got 30% mortality. I got renal failure, 60%, right? Now I'm on the ventilator, I got 80%, 90% mortality. My age is more than 55, I'm already up beyond 100%, right? So we want to try to avoid any kind of secondary injury. Okay, we'll talk a lot in renal about fluid resuscitation. So I'll sound like I'm on a podium again about LR versus normal saline, but normal saline is acidotic at baseline, right? So it is going to cause a hyperchloremic metabolic acidosis. So all the chloride you give to the patient, your body's like, well, shoot, I got all this negatively charged ion. What am I going to do with it? Well, I got to accommodate this chloride that's in my bloodstream, and I got to get rid of another negatively charged ion to accommodate it. Otherwise, I'll be too negative. And what does it get rid of? Here's the bicarb. Bicarb goes into the cells, and now the bicarb is less. That's now an acidosis, right? So it's called a hyperchloremic metabolic acidosis. So is acidosis great? No, especially not in a SIRS process. They already have a lactate that's elevated, right? It may especially require more vasopressors. It's going to cause hyperkalemia in of itself, right? So that's not going to be great. And some people will not complain, but they'll argue, say, hey, LR has 4 MEQs of potassium in it. That's going to raise our potassium. That's 4 MEQs in a liter, right? That doesn't cause any kind of diffusionary or osmotic, not osmotic, but any kind of solute-driven movement. We put 4 MEQs in a liter into someone who has 4 MEQs in 5 liters, right? That's not going to cause any kind of change. LR does not cause hyperkalemia. So they've done research on it as well. It makes theoretical sense, and also research-wise, it makes sense as well, right? The research they did was someone that had a pancreatitis, not pancreatitis, but had got normal saline versus LR. And between the two, they found that someone that got normal saline had the acidosis, and we have acidosis that causes more failure, right? And more failure is going to cause, more kidney failure is going to cause more acidosis, ironically, and it can cause increased mortality, right? So we see here that the mortality is much higher in the saline group compared to the LR group, right? So over here, sorry, 6.6%. So they compare to one who just got LR stuff, right? They found there's a lot more incidence of kidney failure, and there's a lot more incidence of metabolic acidosis and mortality. There was not a mortality benefit for giving normal saline. LR patients did better. Okay, and this is specifically for patients that went to the ICU. To the med-surg floor, it didn't really matter, but they're going to ICU where they're sick. They're going to have a problem there. Okay, so what else? So normal saline is the same tonicity as salt and vinegar potato chips. So it's going to be very, very acidotic, and it's going to be very, very harsh on the system. As we mentioned, normal saline causes AKI, it increases mortality, as based on the evidence we saw over here. There's a worry that LR is lactate. Oh shoot, lactate, lactic acid. That's going to make someone acidotic. No, no, it's sodium lactate. And sodium lactate is processed in the liver and converted into bicarb. That's going to be the opposite of making someone acidotic if I increase someone's bicarb, right? So sodium lactate is converted in the liver into bicarbonate, right? Oh shoot, well, if you have no liver, if you have a liver disease, that's going to cause the sodium lactate to be broken down into the lactate that we were worried about in the first place. Well, your liver has to be like absolutely dead, like it's not working 100%, you're in a liver unit and you're on a transplant list. That's maybe someone we might be cautious with LR. Okay, so what else? They're saying that it's hypotonic, so it might cause cerebral edema. They did studies, it's not. That's a complete myth. It's, oh, it's so much more expensive. Look at all the ingredients in it. It's like 25 cents more than normal saline. So it's not going to break the bank when you give LR, especially if someone dies because you gave normal saline versus LR. It's like, oh, if we just chose LR, how much? It's been 75 cents for 3 liters. I don't know, right? Compared to other medical costs. So there's a lot. We'll talk a lot more about fluids, and we'll get off our soapbox about LR versus NS at this point. All right, so nutrition. So nutrition is another thing that had a lot of research behind it recently, last 10, 15, 20 years even, where we said that, it's not great to be NPO, right? They did research and they said, you know what, when we starve people, they don't improve, right? They say there's not one research study that says if I starve this person, they will get better, right? That is not any kind of science that, there's no illness or disease that is shown to demonstrate from keeping someone NPO, okay? There are reasons you would keep NPO, don't get me wrong. If you have someone that has a GI bleed, or oh, well, Aaron said I got to feed them, all right, that's obviously we're not going to feed someone if they have an active GI bleed, whether it be lower or upper. If they have like mesenteric ischemia, which is also GI bleed, right? Now we're back to square one. They have a bowel that has no perfusion, they're not a candidate for feeding as well. If we have a bowel that is discontinuous, a bowel that is not sewn together, right? A bowel that is open or perforated, that is someone you cannot feed, right? There are some very, very rare instances where you would use TPN, right? If they got stabbed in their gut or like the esophagus, for instance, right? It's really hard to repair an esophagus. Maybe they might wait for it to heal up in 7 to 10 days or even longer, and they might need TPN at that point. But if you give TPN versus enteral nutrition to a patient, whether it have pancreatitis or otherwise, they found it causes harm, right? It's something that if you give this to a patient, it actually makes them die more. So it increases pancreatic necrosis. Is necrosis good in the pancreas? No, it has a much, much higher mortality, as we pointed out. It was like 17% mortality compared to someone who does not have necrosis. So if you give TPN to a pancreatic patient, a pancreatitis patient, that's going to worsen their outcomes, right? Even non-pancreatitis patients, it causes harm to these patients, right? It causes them to develop fungemia. Well, that sounds like a fun time, right? But no, they're not. It's not. The fungi here are not fungi. They are going to cause a rampant infection. It's very difficult to treat with, very, very toxic agents like fluconazole, and those other agents are very, very toxic to the body to begin with, the heart, the liver, and such. So not only does it cause toxicity to the organs, but it also causes collapses. When we start TPNs, they have very, very high what in it? What does TPN have that's in high amount? Glucose, right? It's usually D20 if it's centrally given. All right, we have central veins, and now you have that glucose that's super rich. That's like bait for bacteria to grow, and also fungus as well. It's a warm, moist environment, especially. And we could give it peripherally, but peripherally is just D10. That's still a lot of dextrose. That's going to potentiate collapses from growing, right? And these lines have to be in for 4 weeks, 6 weeks, whatever it may be. Right, and then we have, again, the only time we should be doing TPN is we did a good trial of enteral nutrition. What is enteral is stuff that uses the enterum or uses the bowels, right? So we have different varieties here. We use the stomach with a nasogastric tube. We can use the duodenum with a nasal duodenal tube or a nasal jejunal tube if we're using the jejunum all the way down here. Right? We have different devices we can insert to get all the way down there, right? Like Dobhoff tubes are an example of an instrument that has weighted at the end, and you wait 2 to 4 hours, and then your stomach will automatically push it into the duodenum. Okay, so doing pancreatic rest is never research-based, it's not evidence-based, that's going to cause worse outcomes. If you say, oh, we're just going to let your pancreas rest for a little bit, we're not going to make it work hard, we don't want it to secrete more enzymes and digest itself. Well, that sounds like a really good, good rationale, but the research, says no, says otherwise. The best thing is to give them pain medication for the pain, because we know they're going to have pain with digestion. But we give them pain medication and we get them the nutrients they need to get through their surge response, to get through this process, right? So early nutrition, whether it be PO or enteral, doesn't matter, just get food in them somehow. That's going to improve their outcomes. Okay, so it's going to decrease their hospital length of stay. It's going to improve ICU and hospital mortality. Okay, especially patients with pancreatitis. That's where it's studied the most, is pancreatitis patients. Right, so it increases intestinal function, therefore it doesn't shut down, because if it shuts down, now you have an ileus. Now you have an ileus and pancreatitis. That's two issues at once, right? So if we get an ileus, then you can't feed them. If you can't feed them, you can't get better, right? Because again, starvation does not cure disease. And then we got pancreatic necrosis is going to be improved because we're able to repair better, right? We have decreased GI symptoms. So if they get the nausea and vomiting they got with their epigastric pain, we can give them agents to fix their nausea, and it actually will improve over time as we give them food. If they really have the nausea vomiting, we could give what? We could give one of these little Dobhoff tubes, right? To give post-pyloric feeding. That way the food's getting in their gut somehow, right? Because usually when you have nausea vomiting, it's really from the stomach getting irritated, right? Maintains gut integrity, because if our gut has an ileus and it stops and breaks down, that's going to cause more bacteria to proliferate, and more bacteria will translocate and cause a sepsis process. So that's not something we want to entertain if someone has pancreatitis, which is a huge insult to someone's body. Right? So it decreases stress ulcers, because if you have food in the gut, that's going to provide blood supply to the gut, then you can wash out the hydrochloric acid, and you can have protective enteral nutrition. Also, it prevents the gut from being eaten away by the acids from the stress process, right? There's things where say, oh, you can't give enteral nutrition because I don't hear any bowel sounds. Bowel sounds have been debunked in the ICU, right? Maybe on med-surg floor you can do bowel sounds, but in the ICU it's only a 50% chance that you're going to hear it or not hear it, right? They compared hearing bowel sounds versus ultrasound, and we got it wrong. We're just as good as flipping the coin whether bowel sounds are present or not. So it's better just to try it and see if they do well or not, right? If they don't do well, then yeah, we have other options. We can maybe they have like nausea, vomiting because of that, right? We can go ahead and give we can do post-pyloric feeding if we need to, not jump to TPN. Okay, neuromuscular blockade agents. So the worry is, oh, I'm going to stop all muscular function. And wait, isn't the GI tract have a muscle too? That's going to cause my GI tract not to work. I can't feed this person. Well, neuromuscular blockade agents work on skeletal muscle. They don't work on smooth muscle, right? So when you do pupillary checks on someone that's paralyzed, do their pupils work? Yes, because they still have pupillary function. That's a smooth muscle, right? So smooth muscle still works. That's perfectly fine, right? So we can still feed these patients. If they're really worried, you can reduce the rate, right? But it should still be given even if someone's paralyzed. Why would they be paralyzed? Because pancreatitis causes what? Causes ARDS, and ARDS we need to sometimes take control and breathe for them, right? What else? Head of bed, 30 degrees versus flat. So, oh, they're flat and hypotensive. I can't feed them. Well, they did research, and there's no difference in aspiration whether someone's head is flat or whether head is up. So you're not at risk for aspiration if your head of bed is flat. Okay, and then vasopressors. So vasopressors is like, oh, they got vasopressors. I'm going to route blood supply from the gut. Well, come to find out, if I keep some food in the gut, I'm going to have blood supply to the gut, and I'm going to prevent ileus and prevent ulcers. So I still want to have food in the gut to avoid the gut from shutting down and getting ileus and worsening outcomes in of itself, right? Once they get that initial resuscitation, right, you're not going to you have like 3 options in front of you with a patient with blood pressure of 60/40. He's like, I'll be right back. I'm going to get some tube feeding. That's not your priority. Once they were resuscitated, you need to get some food on board. The goal is, again, within 8 hours, 8 to 12 hours during your shift at least. To get intubated at the beginning of your shift, you should, by the end of your shift, get some tube feeding started. I think you probably resuscitate them adequately if that's the case, right? And then open abdomen, there's a worry like, oh, they got an open abdomen. I can't do anything about that, right? As long as the bowel is connected, you can feed them. If the bowel is open and the GI tract is open, then no, you're not going to feed them. We said if the bowel is perforated or discontinuous, right? discontinuous, then that is someone that cannot be fed. Okay, so how do you feed them? It's going to be PO or enteral, right? And it's a low-fat diet. We don't want the lipase, going crazy. We're going to make it a low-fat diet, and it's better to not be clear liquid. It's to need low-fat diet and with nutrition and calories attached, right? It's really hard to get calories instead with a liquid diet, right? Unless it's enteral nutrition. All right, so if unable to tolerate it, we can then do enteral feeding if we need to. It's going to have better outcomes. Oh, I don't want an NG tube. It's like it's going to make you leave the hospital more if we do this versus if we don't do it, right? And we can always do what are called trickle feeds or tickle feeds, where we're going to feed the gut and we're going to just do little tickle feeds. We're going to just tickle the bowels, and we're going to give a little 10 mLs an hour. That's perfectly fine. So in that first 12 hours or the first 10 hours of your shift from intubation, you should at least start something at 10 mLs an hour. No one's going to argue with you at 10 mLs an hour. You're not going to overdo it 10, right? So 10 is perfectly fine. And then usually day 2, or let's say if that was day 0, day 1 you would go ahead and increase it. Day 2 you would increase it. Day 3 you would increase it. And then dietary nutrition services will weigh in and say, hey, we should have this amount of calories we should feed the patient. And then you would get your goal rate from them, right? But we can always start them at 10 at least. Okay, and again, we can advance as tolerated, and post-pyloric feeding is ideal to avoid nausea and vomiting, which we know pancreatitis patients have. All right, so maintaining your enteral nutrition. So every ICU patient needs to have at least 25 kilocalories per ideal body weight. And we do ideal body weights with our tidal volumes, right, on our vents. So once we have that number, right, it's not the number they are. Like they can weigh 140 kilograms, but that is not how much. We're not going to give 25 kilocalories per 140. If they're 5'2", right, it's going to be 50 kilograms plus 2.3, right, for each inch. So that's going to be what, almost like 54.6 would be their ideal body weight. So that is 25 kilocalories per that, right? So we're not going to overdo it. You can see here in the ICU in the acute phase, our goal just by day 1 is to get them 25% of that 25 kilocalorie calculation, right? So it might be just 10 mLs an hour. There's little cards here, but it gets really complicated. Really, it's just 10, right? Start them at 10 mLs an hour. Doesn't matter what feeding you start, you can mess it up. You really can't mess it up. 10 mLs of Nepro, 10 mLs of Glucerna, 10 mLs of Jevity. Doesn't matter. I usually go AF. I go Vital AF because that's the strongest high calorie solution, right? And we'll go ahead and start that. If the sugar is like 400, okay, I'll maybe use some critical thinking. I'll use Glucerna because a lower glycemic, or I guess a longer glycemic formula. But as far as 10 mLs an hour, they can change it the next day. They say, oh, let's actually change that to this one, right? This one be actually created in this situation, sure. But you actually started some calories on board so they can start, making more antibodies or making more white blood cells and making the bone marrow do its thing, because the bone marrow needs ATP. And where do you get ATP from? From glucose, right? Glucose is our number one thing that we get energy from, right? Yes, you could get it from proteins and fats, but do you want this person start to break down their proteins and fats when they're in an acute process? No, you want them to start building as much as possible. So day 2, we're going to increase that to 50%. So it was 10. Was the calculated 25%? Great. Now we go up to 20, and then we go up to 75%. And by day 4, we should be at 100% of our calculation. And dietary nutrition services is there to help us out. They're there to say this is where our goal rate should be, right? And they might adjust it based on the formula, because certain formulas are more calorie dense than other ones. Certain ones have more water than other ones. Certain ones have more fiber than other ones. So if they have like diarrhea with enteral nutrition, we can change it around. So that's why they're useful on the multidisciplinary team to help us achieve these goals. And also day 4, what else is happening? We are adding protein. It's time for protein. 1.5 kilocalories at day 4, day 3 to 4. All right, 3 to 4, day 3 to 4. So we want to get some protein on board because they were probably breaking down protein if we were in not a starvation state, but in a stress state. We're going to start breaking down glucose, we're going to start breaking down lipids, and we're going to get a lot of cortisol released. And what does cortisol do? It breaks down fats and lipids, but it also breaks down protein. It's the only hormone that breaks down protein. So we want to stop that by giving them some protein to munch on. Okay, so we start low, right? 1.5, 1.3-ish grams of protein per kilogram of ideal body weight again, and then we're going to start increasing this stuff as soon as they start getting better outside the ICU. Because as we take out the enteral nutrition, right, they're going to start eating by mouth, they're going to be super fatigued out of the ICU. They're not going to be the person they were beforehand. They're going to have like 20% of their meals. So we really need to like encourage, supplements and making sure they're getting the calories they need. And that's what their job is outside the ICU as well, to make sure they're getting the appropriate amount of calories and protein to recover and actually leave the hospital. Okay, so again, start at about 25% of our goal. And again, that's just how much? 10, right? It's not coming out clear. So 10 is how much, 10 mLs an hour is what you want to be starting on these patients, right? These are called what kind of feeding rates? These are trickle or trophic feeds. If you want to be fancy, you want to impress nutrition services. Hey, can we start on trophic feeds? Oh, yes, my boy, we can do that. Let's go for it. Okay. Anyways, after you resuscitate them, 10 mLs an hour. That's our goal. Okay. And then the dietary can modify it. They can say, hey, I noticed you're getting a lot of propofol right now. You're getting 50 mics of propofol. Yeah, they got ARDS. They're really sick. I really have to get them snowed to get them the oxygenation they need. So, well, do you know that propofol has lipids in it? He's like, you say, yes, I do. It has egg and soy proteins, doesn't it? Yes. So yeah, anyways, it has a lot of lipids in it, and therefore dietary will adjust the formula rates based because you're getting propofol. So they will make those adjustments on the back end, right? So they say, hey, if you're getting more than 20 mLs an hour, for 24 hours, they're going to adjust your tube feed goal rate. Instead of being 60, it'll be 40. It's like, why I never seen Vital AF at 40? It's like, because they're getting a lot of propofol. That's a lot of caloric source, right? We don't want to overdo the amount of calories you're giving them, because that can cause refeeding syndrome, which can be another consequence of patients with too many calories, right? We want to make sure we're just doing what the body can support. If they're underweight, instead of using the ideal body weight, we might use the actual weight because they are underweight. If they're morbidly obese, they do require a lot more proteins than the average bear. So they're going to, instead of 1.5, they're going to be getting a whole, almost double, like 2.25 to 2.5. Okay, and then modifying calories and protein. Sometimes they'll say, oh, you got to have a low protein diet for renal failure. The BUN is going to go up if that happens. If BUN goes up, they get uremic encephalopathy. They get confused. They're going to aspirate and die. It's like, well, there's no research that supports that, so please stop. And then same thing with liver disease. It's like, oh, you got to do that because if I give too many proteins, they're going to not be able to form BUN, and ammonia is going to go up. They're going to get hepatic encephalopathy. They're going to get comatose and die. So there's no research behind that as well. They need proteins. Actually, when we talk about hepatic encephalopathy, you want to encourage protein intake. Okay, so that's been completely false. Okay, and then Dallas patients, they lose protein and amino acids through the Dallas membrane. So you have to give them actually a lot more protein, even more than an obese patient, because they are going to be losing protein, and now they're going to be in a catabolic state where you're starting breaking down stuff, or anabolic state. We start breaking down stuff. Okay, last little bit here, you're going to stop checking gastric residual volumes. When we check gastric residual volumes, it actually worsens outcomes. It causes harm. It makes patients die more if you check residual volumes, right? So why? So because it's a huge inflammatory statement to say this. I'm not going to check out my patient to die. It's like, well, shoot, they're fired up. So why would you do that? Because the thought was, I don't want that volume to get so high that they're going to start aspirating, right? Because all of a sudden it's going to get to the point where nobody's checking and they're going to aspirate. Well, you are all trained nurses, and you're trained for this reason, right? To know that if someone's stomach is super, super big and they start vomiting all the time, that's a risk for aspiration. But just having a residual volume of 750 in their belly does not lead to aspiration pneumonia. There's all kinds of research and evidence to support that. That high volume does not equal aspiration. A high volume with vomiting and distension and such, and like an ileus yes, that's going to put you at risk. So those are the times you assess the gastric residual volume, right? Same thing if you have like a bladder scanner, right? You don't do a bladder scanner every 4 hours, do you? Right? You do a bladder scanner when you note that, oh, they haven't peed, and oh, their belly is full. Oh, they got a little bit of pain down there as well. That is when I would do an assessment, right? Same thing for like an EKG. I see, yes, we have EKG. That's probably a bad example because we have EKGs all the time, but we do a 12-lead EKG proper once we saw some changes, right, in our assessments. So gastric residual volumes, so they said in 2006, they said if 500 mLs, that's safe. You could give 500 cc's back to the patient. How much is 500 cc's? That is 2 cups. Right? This guy's probably more than 500 cc's, but our monster over here, that's what is it, 340 or something, 320? 473. So that is 500 cc's. Can you down a monster, right? I mean, it's really hard to down because it's carbonated and such, but if it's water, right, 500 cc's is nothing, right? You can probably, I wouldn't recommend doing 2 monsters. I would recommend doing two water bottles, right? That is perfectly fine to consume. That is not going to break the bank in an adult population. That's not going to make someone aspirate. Oh, if I give 500 cc's, that's so much. Because, you know, how did I get that 500 cc's? I had to empty a 60 cc syringe 9 times. Like, oh, that was a lot of work, right? So first of all, why are you doing that, right? Unless they have distension and abdominal pain, or, you know, a lot of nausea and vomiting, that's when we should be assessing it, right? That was 2006, they said 500 cc's. In 2010, they said stop checking gastric residual volumes. Don't even do it, right? So now it's 14 years later, and we're still doing it sometimes, right? And it's an impediment to routine nursing care. You got better things to do than to be checking residual volumes. It takes good 10 minutes to empty like 12 syringes. Like, guess what I got? 700 cc's. Cool, right? Let me get you a gold star, right? So that's not going to do much unless they actually have symptoms, right? And then unnecessary interruptions. So what happens when they get 700 cc's? Say, oh, I'm going to hold the tube feeding and recheck in 2 hours. Oh, it's 600 now. I'm going to hold it again for 4 more hours. And oh, I'm going to give metoclopramide. I'm going to prolong the QT, and they're going to go in the torsades. Or I'm going to give erythromycin and prolong the QT. I'm going to, you know, do X, Y, and Z. I'm going to hold it even more. And now you didn't give them nutrition for 12 hours of the day. Is that going to help anybody recover? No. So that's another reason why it causes harm. Okay. Also, the volume, like 600 cc's, is not a lot, right? That's like a monster and a half, or a water bottle, a small water bottle and a half. You produce how much fluid per day in your mouth, for instance? How much do you produce? About 2 liters in 24 hours is how much you're producing, right? So conservatively, that's about 100 mLs an hour you're producing. So if you produce 100 mLs an hour and another 100, it takes your stomach about 2 to 4 hours to empty. That's 200 cc's, 400 cc's, maybe even 600 cc's just right there, just from salivary stuff, right? And then what about your stomach itself? It produces gastric acid. Gastric acid, you put out 3 liters per day. That's 5 liters you're producing just in 24 hours. That's a good, you know, 150 mLs an hour. And if someone has sepsis or shock or an insult to the body, their stomach's going to start to shut down a little bit, and they're going to have extra fluid going around. And then you add on tube feeding on top of that, and you're like, oh, I'm going to hold it because it's 700. It's like that's physiologic. That's what's going to happen, right? I'm going to have this extra volume. Okay, and if they truly have a lot of nausea, vomiting, a lot of distension, again, we have more tricks we can use. We can use a Dobhoff tube or a small bore feeding tube. That is, these guys are weighted at the end, and they can then go past the pylorus, and we can feed them, you know, so they don't have nausea and vomiting. And we have other agents we can give, like metoclopramide and erythromycin, if truly they are have nausea and vomiting. Okay, and another thing is please don't stop tube feeding if you're going to go for a routine procedure. Again, they are trained professionals. The anesthesiologist is trained to manage this, and they've done the research. It's not just something that I said. They've done the research and said they don't get aspiration when you don't keep them NPO, right? NPO for 2 to 4 hours before the procedure is fine. And if you're really, really worried, they got distension, oh, I'm feeling nauseous, guess what? We can empty it, right? We can empty the stomach. That's perfectly fine. Okay. Same thing for like spontaneous breathing trials. I had a anesthesiologist intensivist who told me, hey, I said, hey, we can extubate them, right? They say, how long they've been NPO? I was like, what? How long have they been NPO? Yeah, I don't want them to aspirate because if I take out the tube, they might vomit and die. It's like, oh, okay, I haven't heard that one, but that is something that's out there in some old books, right? So that's, if they're really, really concerned, it's like, I'll just put it to suction right now. I'll feed them later, right? Once they get extubated, they're awake and alert, I'll feed them dinner. I promise I'll get that 250 cc's back in them. No problem. Okay, so if they are vomiting, we can place a post-pyloric feeding tube, a Dobhoff tube, a erythromycin, metoclopramide can improve gastric emptying, so that can help as well. Hopefully, will improve the nausea, vomiting, and our goal is not to produce residuals, but our goal is to improve distension, avoid ileuses, and again, give them calories that they need. So pancreatitis treatment. So we talked about enteronutrition is pretty important to get them fed, to get them the calories they need. But what else can we do, right? So we want to make sure we are treating the underlying cause. If they have a gallstone in place, we got to get the gallstone out. So the easiest way to do that is with a ERCP, right? So an ERCP is an option to get that stone out of the way, right? Yes, ERCPs 5% of the time can cause pancreatitis. We just got to be alert to that as well, right? It's not like super urgent, but we should get it done once they are stable. And usually by discharge, they might even recommend a cholecystectomy, taking out the gallbladder, so they don't get stones in the future because they develop pancreatitis for the stones, right? Fix the triglycerides. So fix the triglycerides is, if they're more than 500, they're at risk. More than 1,000, they're at extremely high risk of getting pancreatitis. And to fix triglycerides, all you do is give insulin drip. So insulin drip not only lowers blood sugar, but it converts free fatty acids into triglycerides, it breaks down triglycerides into free fatty acids to get absorbed by your cells to then use it for the cell membranes and other fun stuff. So insulin drip is great for that. We can take out the lipids with plasmapheresis as well. We're going to stop any kind of offending meds, like we mentioned, like furosemide is on there, as a sulfa, are things that can induce pancreatitis itself. Traditionally, what they said is wrong, is that they do massive fluid resuscitation. We know it's like we're going to kind of cap it out 2 to 4 liters. That's the most we'll probably give them. Then really they need to get vasopressors on board. We mentioned that they want to do NPO, a bowel rest, and NG tube low maintenance suction. If you put NG tube low maintenance suction, you're removing content for the bowel to process. So you need to have something in the bowel for it to do. And what's better in the bowel is food, right? And antibiotics we don't give until they actually get worse. So, well, that sounds bad. I should give it early so they don't get worse. Well, we only do it if they have indications for it. And that's what usually after about 10 to 14 days, when they're getting clinically worse, we know that now they probably have a necrotizing necrotizing pancreatitis that occurs after about 10 to 14 days. Is it going to flip of the coin? Well, it's not really flip of the coin. It's like 10%, right? But it is possible for them to get really bad and require more antibiotic therapy, which we'll talk about in the next slide. But what's here we're going to focus on is treating pain. So the pain needs to be under control. So opiates, yeah, they can be used to treat the pain, but we have this step ladder that we need to start. So the first step is starting Tylenol, right? So first PRN Tylenol, and then it can be scheduled Tylenol, right? So Afiramev IV, if we're really concerned about bowel stuff, we can give that first, and then start them on scheduled Tylenol around the clock, so that their pain is somewhat controlled by 10% or 20%, however much the Tylenol is helping, right? And then after that, we're going to step it up to something that is not opiate related, but is an adjuvant, right? Like a pain dose ketamine, or they have clonidine is the same thing as dexmedetomidine or Precedex. So these agents can control pain as well. When we talk about IV sedations, those guys also have provided analgesic sedation. They provide analgesia and sedation. Ketamine can suppress the respirations at high doses, so usually it's probably a vented patient. And this is where we're going to start adding on PRN opiates at this point, all right, to control their pain for breakthrough pain. And then step 3, we're adding on some, you can do a lidocaine infusion, you can do a gabapentinoid. That's your gabapentin or pregabalin, will inhibit the pain impulses. It's a great milieu of pain meds to help control the tense pain of pancreatitis.
Is that why pregabalin is controlled?
Pregabalin is not controlled, but it's because it's expensive. That's why. Yeah, so gabapentin is much cheaper than pregabalin. Pregabalin is coming off the market soon, and then it'll be just as cheap, hopefully. All right, so it has better efficacy. So gabapentin will go away, hopefully. All right, and then NSAIDs. NSAIDs can only be used if you have a no AKI and no ACS, no heart problems, no kidney problems. Then NSAIDs can be used. But usually you don't give NSAIDs in the ICU because of those reasons. They're a high risk for AKI, they're a high risk for cardiac decompensation. So if they don't have that though, then the NSAIDs are perfectly fine. Okay, so around the clock Tylenol, we got ketamine, and we have epidurals. So epidurals, if you have anesthesia involved, you can use an epidural in here as well. So plus epidural is something that we can use to numb, I think it's called a celiac block, where they're able to go in there and cut off the pain at the source, just like you do an epidural for pregnancy, do an epidural for pancreatitis, right? That way they can have a quicker recovery. All right. There's always an opiate alternative. Can you use opiates? Absolutely, you can use opiates. Can you use morphine? Absolutely, you can use morphine. Does it contract the sphincter Bode? Fine, yes, it does. But does it worsen outcomes and cause them to worsen the pancreatitis? The research says no. So it's perfectly fine to use morphine. But you're often going to see Dilaudid just because that's everybody's like ingrained. No morphine for pancreatitis. Okay, so analgesic drugs, we got nutrition, that's going to help with pain as well. As we give them nutrition, it's also going to help with calories that they need for their acute process. ERCP is required to get the stone if it's gallstone related. Otherwise, we're removing the underlying cause. We're trying to fix what's causing it in the first place. Okay, so pain control and nutrition. We might need to resuscitate them, really cap at 2 liters, 4 liters at the most. And then we need to look to see what are the underlying causes. Do they have a gallbladder situation? Do they have a triglyceride situation, a calcium situation? Is liver involved with like an ascending cholangitis from the gallstone, which we'll talk about coming with gallstones. But all these things we're trying to fix in the meantime. And when do antibiotics come into play? That's usually about 10 to 14 days later, right? So that's at day, that's not immediate, right? That is later.